Welcome, everyone. I'm Dr. Marc Greenstein. I'm a urologist here in Sandy Springs. Many of you may know me because you may actually be my patients. And tonight we're going to do a talk on erectile dysfunction, a topic very near and dear to many, and especially to me, who's a urologist. So I work with a couple of people in the area, Doctors Neil Patel, Rut Patel, Casey McCullough, Vishal Balani. Those are a few of my partners here in the advanced urology practice. We are a bunch of young group urologists in the Sandy Springs, Johns Creek location. We also have other offices in Snellville, Marietta, Alpharetta, Roswell area, Decatur, Lawrenceville, etc. And like I said, tonight we're going to talk about erectile dysfunction. A little bit of housekeeping. So make sure you're using Chrome or Firefox. You can see that there is a chat section there, and I'm gonna knock out this lecture, and then we're gonna spend some time going over these questions, and we'll handle everything, I promise you. So like I said, my name is Marc Greenstein. I've been in private practice since 2003. I trained up in Philadelphia. I worked in New Jersey for 15 years, and then my family and I relocated to the Sandy Springs area about 2 years ago. I was, I'll say, recruited by my partner and long-term friend, Casey McCullough, who's in the Johns Creek office. And it's been a great move to the Atlanta region. My family's doing extremely well here. Everything was going nicely, and then COVID hit, and then of course everything went on stall. So I do a lot of men's health, specifically low testosterone and erectile dysfunction, and other parts of urology such as cancers and kidney stones and pelvic pain disorders. All right, so what's on the agenda? We're going to talk about erectile dysfunction. We're going to talk about the treatment options. We're going to show you a little video, and then we're going to hit the questions and answers. All right, so ED is basically the inability to sustain an erection successful enough for intercourse. So in other words, a partial erection is considered erectile dysfunction. A short-lasting erection is considered erectile dysfunction, and of course, not being able to get an erection at all is considered erectile dysfunction. It affects millions of people every year. 1 in 4 men get it. They think 30, if not more, million men have it across the country. Numerous causes cause erectile dysfunction. Injuries, diseases such as heart disease and diabetes. So we know that diabetes causes injury to small blood vessels and nerves. That's why your doctor says that for diabetics, you have to get your eyes checked. You should see a foot doctor to make sure your feet are okay. Some people need to see neurologists. And if those small vessels are not working, the small vessels of the penis are not going to work, or of the nerves to the penis are not going to work. Same thing with heart disease. If you have these very little blood vessels that feed your heart, that's the blood vessels that your cardiologist may put stents in. Those blood vessels are essentially the same size as the blood vessels that head to the penis. And so if those blood vessels are diseased, the ones in the penis are diseased, and vice versa. Injury, specifically neurologic injuries such as stroke, brain injuries. Stroke is actually a very high cause of erectile dysfunction. In our world, we see men getting erectile dysfunction from prostate diseases such as prostate cancer, prostate enlargement surgery, and then of course there are medications out there that create erectile dysfunction such as high blood pressure medications, diabetes medications, and alcohol and tobacco use. We also line up with drugs because they're considered a drug. So one of the things that's highly published in my world is the idea that men with erectile dysfunction could have underlying heart disease. And so we may not see the 70-year-old guy that's got a known history of heart disease, and maybe he's had a stent in, and then he gets erectile dysfunction. It could be the opposite. We could see a 45-year-old guy who's having trouble getting an erection, and that's a precursor that he has underlying heart disease. And many times we'll get people to get to a cardiologist sooner than they realize that they need to get to a cardiologist. Aging, chronic diseases like we just mentioned, medications like we just mentioned, and also lifestyle like smoking and alcohol are linked. Aging, well, as we know, blood vessels are not as good as we get older. The nervous system is not as good as we get older, and your testosterone is not as good as we get older. As men get older, their testosterone starts to drop about 1% a year after the age of 40. And when you put all of this together on top of just other illnesses that happen, like we mentioned, diabetes and hypertension, it sets up for erection problems. So specifically for diabetes and hypertension, as I just mentioned, it's linked in the older population, although we do see it in younger people. We see it with poor sugar control. So I'll see a lot of guys who say, well, I'm pre-diabetic. Well, you're diabetic. Let's just put it that way. If you're having trouble and your sugar's on a daily basis or in the low 100s, you're diabetic. It's time to act and do something, because years of a slightly elevated sugar is just damaging your body. And the same thing with hypertension. We see a lot of people who are on their way to becoming hypertensive. Their pressure is maybe 140/90. They feel perfectly fine, but years of that does damage on the body. It hurts the blood vessels, it hurts the heart, and then it hurts the nervous system. Chronic diseases, these things just add up, as we keep mentioning. Diabetes, it's, the high sugars just build and build and build, and they just hurt the blood vessels and the nerves. Prostatic disease, if you have prostate surgery, and the prostate surgery, you had to take the nerves out in order to control the prostate cancer, those nerves are not getting better. And it just builds year after year. Same thing with peripheral vascular disease, which is part of coronary artery disease, high cholesterol, and hypertension. So with prostate cancer, one of the things that we do commonly around here is we either take that prostate out or we're going to do radiation. So when we do prostate cancer surgery, if this is your prostate, these are the nerves that head down to your penis over this way. We have to separate those nerves out from the prostate in order to do nerve-sparing surgery. But nerves are very sensitive. The second you touch them is the second they get stalled and they go, we'll say they go numb. And if they go numb, the ability to get the erection goes on vacation for a little while. Now, the nice thing about surgery is that nerves can regenerate. They can get stronger. We can give guys medications and therapies to help build that erection back up, help that nervous system get going again. Radiation's a little bit of the opposite. Radiation is the gift that keeps on giving. Once you give radiation, there's a constant effect of scarring and injury to the blood vessels in that area. So if this is the prostate, once again, these are the nerves. And when the doctor either puts seeds in or does a radiation field to the prostate, there's always going to be a scattering into those nerves. Now, those nerves are not going to get hurt right away, but over time, as the blood supply decreases, as the nerves get damaged little increments at a time by the radiation, then you're going to start seeing that the erections are not going to be as good at the time of the radiation. So it's common for me to see a person that gets radiation and then 2 years later, they can't get the erection again, or the erection is not as good. Smoking, well, we all know smoking is bad. It's the #1 cause of lung disease. In my world, it's a cause of bladder cancer. It's a cause of kidney cancer. And then smoking just damages blood vessels. If the blood vessels get damaged, the blood vessels can engorge, and you can't get the erection. Same thing with diuretics, also known as thiazides, like chlorothiazide or chlorthalidone. And then the beta blockers are also very good at causing erectile dysfunction. And then there's numerous other medications like antidepressants and some of the diabetes pills, and even some of the prostate medications like Flomax can cause, or tamsulosin and finasteride, they can cause erectile dysfunction as well. So how does an erection work? You get stimulation from the nervous system. You get a little bit of a spike of testosterone. That drives increased blood supply to the penis. And you can see on the little diagram here, there's like it almost looks like a penis emoji. You have a spongy tissue, which is the corpus cavernosum. Those are the two eyes here. The mouth of the penis emoji is the urethra. And in the center is these little red dots, and that's the blood supply to the penis. So there's an increase of blood supply in the central part here. The blood then leaks out into the sponge of the corpus cavernosum, and it starts to engorge. Then the connective tissue that surrounds the corpus cavernosa, the sponge, it's rigid. It's normally firm. With blood supply in it, it tightens it, it makes it even more rigid, and the blood stays trapped inside the penis. The veins, the little blue circles here, the veins collapse, and the blood stays in the penis, and you have an erection. Good job. All right, so what are the therapies? All right, so some of the therapies, years ago, there was only one thing called yohimbine. It was the only drug on the market, and it was basically a stimulant to try to get a guy excited. Didn't work very well, but it was all that we have. And then Pfizer invented Viagra, and the world changed, for a better place. And Viagra was actually invented to help with what's called pulmonary hypertension. In other words, high blood pressure in the lung system from cardiopulmonary disease. And the guys were like, my blood pressure in my lung system is great, and by the way, I'm getting an erection. And then Pfizer said, wow, let's work on that. And then Viagra was created. To compete with Viagra, there came medicines like Cialis and Levitra. So Viagra was the blue pill, Cialis was the 2 bathtubs, Levitra was the guy throwing the football through the tire. And there's actually another medication out there called Stendra, but Stendra is just not marketed a lot. The nice thing about Stendra is that it has a quick onset, but unfortunately, it's very challenging with insurance companies when we work with these medications. The good news about Viagra and Cialis is that they're generic these days. They're not easy sometimes. They cause side effects. In other words, headaches, facial flushing, upset stomachs, sinus congestion. Some people may see a blue haze, and some aches and pains. The next is actually, I'm going to talk about this slide in a second. There's also these little pellets that can go inside the penis. Let me see if that's on the next slide. Excuse me. Nope. Oh, that is on the next slide. I guess I will talk about that in a second. So another almost a guarantee treatment for erections is a penile injection. So this is what we call bimix, trimix, or quadmix. These are medications that are made by a compounding pharmacy. In other words, it's not a pharmacy like CVS, Walgreens, or Publix. This is actually a combination medicine that's made for the individual. And when it's time to get all excited, the man will say, excuse me. He would load up a little bit of this medication. You just need a few drops of a cc. He would inject it into the side of the penis, and then foreplay starts, and then within 10 minutes, there should be an erection. And the erection should be almost like you're 18 years old again, excuse me. And it should be firm enough, and it should last long enough to have sex. It works great. The downside is that you got to stick a needle in your penis. All right, so it definitely loses its intimacy. So if you're having foreplay and then you got to take a break, sometimes that doesn't go well with the couple. There's some bruising. You're sticking a needle in a place that it doesn't belong, and so you can get black and blue. It's expensive. Your insurances, unfortunately, will not pay for it. It can cause scar tissue. And so the more you put medicines in the penis, it can scar. And next thing you know, you got another problem called Peyronie's disease, and the penis starts to bend. And then the worst side effect is called priapism. That's if you have an erection for more than 4 hours, call your physician. That actually happens, and that's a common thing in my world where a person accidentally overdoses their Trimix or Bimix, and then they have an erection for 4 hours, and then they need rescue medicine or sometimes a procedure to make it go down. and that's actually very common in my world. Vacuum devices are not wonderful, but they're out there. It's basically a cylinder with either a battery or a hand pump. And the idea is you pull blood into the penis. So you put this little cylinder over the base of the penis, you create a seal, you use a restriction ring at the base of the penis, hit the button, blood gets pulled into the penis, and then it stays there. I do not have a lot of success with that with my patients, but we will use a vacuum device before someone has implant surgery because there's data that can actually add length and a little bit of girth to the penis when we do implant surgery, which we're going to talk about in a second. Pellets, these are little pellets, or sometimes we can actually get it as a gel, and that goes in the opening of the penis. So right where the pee comes from and where the ejaculation comes from, you can have this little plunger device. You hit the plunger, this little tablet gets dissolved into the urethra, and you have to wait for the medicine to absorb to give an erection. The downside of that, very expensive, $30, $40, $50 a treatment. That's worse than dinner and a movie. 30% of pain. The gels, very expensive, $100, $200, $300 for maybe a 3-month supply. I can't say the success rate is very good. We tried this a lot in the mid 2000s. I don't think I've prescribed a medication like this in a long time. So next we have surgeries. So when the pills don't work, patient is willing to try the pellets, but they don't work. Vacuum device doesn't work. Injections are either not going well, or they're too painful or they're too expensive. Then we have surgical options. So the first surgery to think about is what's called a malleable prosthesis. This is metallic cylinders that go inside the penis. So it's a surgery that we do. It's actually a very quick surgery, and they go inside that spongy area that holds the blood in. And what it does is it's always up and it's always down, one or the other. So it's rigid, and when you don't want to have sex, you just bend it down. The problem is you have a partial erection the whole time. But when you want to have sex, you just bend it up and you have sex. We don't use this except in maybe very high risk patients, patients who we want to do a quick surgery on and they still want to be sexually active. Sometimes we'll use this in other procedures related to erectile dysfunction, but it's not the go-to treatment, but it is available. The cornerstone treatment, the go-to treatment, is what we call an IPP, or an inflatable penile prosthesis. And that's the go-to treatment. That's the gold standard. This is a surgery where we implant 3 devices. That's why sometimes we'll also call it a 3-piece. And usually it's done through a small incision just above the penis. There's other ways of doing it, but that's pretty much the most common way of doing it. So it's about maybe 1.5 inch incision. We open up the sponge areas, the corpora, and we put these inflatable cylinders inside. We then, using the same incision, put this reservoir. You may see it there. It looks like this little white balloon up there, next to the bladder. And then we put the pump itself in front of the testicles inside the scrotum, all through the same incision. And it's about a 1-hour surgery. Sometimes it's less, sometimes it's more. It's a lot of prep work in the operating room with sterilizing everything and cleaning everything. And you go home, same day surgery. And there's a little drain that we put in to help get bleeding out of the surgical site, which is a common thing in the world of surgery. And you go home and get better. And then I tell patients, lather, rinse, repeat. So ice pack, antibiotics, pain medicine, and lather, rinse, repeat. And you do that day after day. On day number 2 after the surgery, you come into the office, you'll be a little sore, you'll be a little puffy, a little black and blue, and we just remove the drain. And then you just keep getting better. Lather, rinse, repeat. This is going to be a little animation that we're going to show you here. It's going to show you what the device does and how it works. So this is a diagram of the reservoirs in blue. The cylinders are in white, and the pump is like this clear thing that sits right in front of the testicles. When a man's ready to get intimate, he will take the pump and start pumping it up like 1 Mississippi, 2 Mississippi, 3 Mississippi. The fluid that's in the reservoir gets transferred into the cylinders, and you have an erection, and then you have a good time. When you're done, there's a little release valve on the top of the pump. You press that, you just squeeze the penis. It pushes the fluid back into the reservoir, and you're done. You can have sex all over again. You can have sex the next day. You can have sex whenever you want. It's really nice because whenever you're in the mood, you just pump it up. It's usually about anywhere between 10 and 15 pumps, and you are good to go. So I make it sound easy because 99% of the time it is easy, but 1% of the time there's some risks. Across the board, it's a 1% risk of infection. Obviously, it's not the most natural thing in the world, but it's the best thing that we have when medicines are not working. It's a mechanical device, so it can try to get out of the body. It can do what's called an erosion. That's very rare. It can move a little bit. In other words, one of the pieces could pop out. That's a little bit. There's some pain issues involved. That's usually in the beginning, and I would say on average, the patients are pain-free after a week, although I do have some people where the pain lingers for a little bit. And then there's always a risk of a device malfunction. It's a mechanical device. The average length of it, well, I will say it this way, 88% of the prosthetics last 10 years. I have a guy in my practice right now who he's had his prosthetic in, I think, for 15, 20 years, and he has what's called a blowout. In other words, the cylinder has bulged out like the tire on a bicycle or on your car. And so we're going to replace that for him. Same idea, same incision, take the old one out, clean things up with antibiotics, put a new one right in. The nice thing is that it should be covered by your insurance. We're very good at working with Coloplast. Coloplast is very good at working with us so that we can get through the insurance barriers, just like anything that's out there. But it is covered by insurance. And if insurance says no, people can pay for it. You know, there's nothing wrong with paying out of pocket for something that will improve your sex life. So there's websites to talk about this, talks about erectile dysfunction and other sexual diseases that are out there, like testicular issues and Peyronie's disease. I have a video that I'm going to show you here in a second. Let me just work my way through it. Okay, and here it goes.
Hi, my name is Stan Rydelic, and I'm 61 years old, and I live in South Carolina.
I'm Teresa Rydelic. I'm 60 years old, and I met this gentleman when I was 15 years old, and we've been together ever since.
I've been married to my wife, Teresa, we've been debating this, 39 years. 39 years. 39 years.
October.
39 years of bliss. About three and a half years ago, I ended up getting ill. I thought I had the flu. It turned out that I had complete liver failure, and so unfortunately, or fortunately, I had to have a liver transplant. As part of the procedure to nourish my liver, I found out what they did is they rerouted some of my blood flow, and so I ended up with a condition called arterial insufficiency, which basically means that the lower part of my body had insufficient blood flow. After I had my liver transplant and I was feeling well again, and then I found out that things were not happening romantically. It was kind of a surprise. So what I did was I asked my general practitioner, and so he immediately says, well, you know what? All you need is some Viagra. So what he did was he gave me a prescription for Viagra. I went home. I remember that evening, I was thinking, oh, how wonderful, Viagra. Of course, it's going to be a great evening. So what I did is I put some music on, poured some wine for my wife, lit some candles, and guess what? Nothing happened. So I went back and, and every time we're going in, it's just like it's 2 weeks or so between, appointments, and it's still like nothing's happening. And you start to really get very discouraged. So the doctor gave me a choice. He says we could use vacuum erection devices. He says, or we can also use an injection. So I said, let's try the vacuum thing first. That was horrifying. Well, first of all, in my opinion, it was horrifying. It didn't really work. So that was like a one-time shot. And then we tried it was Trimix that I tried. And so I thought that was going to be great. Went home, and again, since there was a tiny bit of success, I thought this was going to be a great evening. So you try to get all romantic, and then you say, oh, excuse me, honey, I have to go into the bathroom and inject my penis with Trimix. I did everything that I could, and quite honestly, I had never even heard of a penile implant. And so this doctor I went to, he was a young gun, kind of like, cutting edge, and he says, I think the only thing that we could do, he says, to really guarantee that you can get an erection is a penile implant. So Teresa was a part of the process. She came to the doctor's office with me, and what we did is we had the discussion about it in penile implant, and she said, look, if it means that much to you, she goes, I want you back how you were. I want you happy. A couple things came up. The first one that I worried about was the procedure, a painful procedure. And quite honestly, I was told, and after experiencing it, it's an outpatient procedure. It takes less than an hour, in many cases a half an hour or less. Another thing that concerned me also, and this one's going to sound really, really very strange, but I really worried that I would have the desire to have sex.
Well, it's kind of ironic because that's exactly how I felt. I felt like, well, he's going to get this implant. We hadn't had sex in so long. Maybe that chapter's over. And I think that a lot of women worry that they're not going to be ready for this new adventure like they were. And it actually has been a renewal of our relationship in one area. And so I'm glad. I'm just glad it's freeing. It's taken on where we can be spontaneous, just so different than years before.
There was a romance. There was a spark that was put back that we didn't know went out. The thing that's really, I think, been wonderful with an implant, with the implant, which I honestly, I don't consider I have an implant anymore. It's just, it's a part of me.
Right.
There's no, well, first of all, from the standpoint, if you look at me, if you saw me in the shower or whatever, you cannot tell that I've had an implant at all. And then also from the other standpoint is you have complete spontaneity. There is never anything where you have to say, okay, you know what, I'm going to take a pill and wait a half an hour for it to happen. If you're in the mood, you're in the mood.
Right.
And it turns back the clock. I mean, I honestly feel like we're in our 20s or 30s.
Since the implant, there's a confidence there that is actually very sexy. And that confidence is something that I think the implant did for us. And I don't worry that it was me, that maybe I wasn't something that he was needing. No, we're perfect for one another, and now we have back our love life. If I could give some advice to someone dealing with this, a couple dealing with this, I would say talk to one another, be honest and open and loving, because the answer may be no. The answer may be, no, I don't want to do this. and it may be I've been thinking about this. So I think communication is the key.
If I could give a piece of advice to anyone suffering from erectile dysfunction, it is the fact that you have one life and you have the choice to choose how you live your life and at what level of quality you live your life. So if you're suffering with something like erectile dysfunction, that's fine, you can live with it, but you don't have to. It's something that is so easily fixed, and you could have the quality back in your life that makes you a whole person again.
Okay. All right, so I think you can see from the video there that this is not just an individual disease because this affects the relationship. When you have a couple that wants to be together and they can't, it creates tremendous strain and it creates marital issues. That's a lot of things that go on in my world. And so we not only help the husband, but we help the wife. And so I think it's a great little video to show our patients. So at this point, I'm going to answer some of the questions. So if you have some questions, please enter them into our little chat that you see there. Our first question is, can hormone imbalance affect erectile dysfunction? And the answer is yes. 20% of erectile dysfunction is hormone mediated. In other words, as men get older, their testosterone starts to go down. One of the signs of low testosterone is a low libido. In other words, if you'd rather have a cheeseburger than have sex, you know that your libido is low. The other is that if you are no longer the man, if you are no longer waking up with an erection in the morning or in the middle of the night, that means that your libido, that means your hormone is low and your libido is bad. The way men are put together is as you sleep and as you have what's called rapid eye movement sleep, that's when your brain is at its strongest and it's working really hard. Your testosterone should be surging. If your testosterone is not surging, that REM sleep is not going to be about intercourse. It's going to be about doing some garden work, having a hamburger, watching Netflix, as opposed to thinking that you're 18 years old again and you're making out with someone in the bleachers at high school. So if you have those things, we will do a screening blood work for low testosterone, and that entails just some morning blood work. Because remember, it's in the morning we want to do this. So before 10 o'clock in the morning, we'll have you come in and draw your blood. And if we see that the testosterone is low, we're going to call you up and say, hey, Mr. Smith, your testosterone is low. We need you to come back and do one more blood test. And if we see 2 levels that are low, we bring you come in and we talk about the options of boosting the testosterone. I've had a lot of guys where they have this erectile dysfunction. We catch them that they have low testosterone. They've been using Viagra or Cialis or something like that with mixed results. We get their testosterone normalized and they are doing great. So there's a definite subsection of that. The next question, a husband had prostate cancer and had it removed. So in other words, he had a prostatectomy. He now has ED. It's been 3 years. All right. So if that person came into the office, let's pretend that they had surgery, in Florida. They moved to Atlanta and they need a new urologist. And by the way, my prostate cancer is under control. My PSA is 0, but I can't get an erection. So we would take you down the path. We would try some oral agents like Viagra, Cialis, and a lot of times I'll put guys after their prostate surgery on a daily Cialis to stimulate that blood supply. We want blood supply in that penis. I may even put that guy on a vacuum device and use it more as like a therapy as opposed to using it for intercourse. In other words, every day, suck the penis, get the blood supply in there, suck it with the vacuum, get blood into the penis to try to get that sponge engorged. If those aren't working, then we bring you in We do a diagnostic test. That's a penis ultrasound. We are going to look at the blood supply at your penis, just like when you go to the heart doctor and they do an echo of your heart. You listen to the lub dub of the heart. There's a lub dub of the penis. Then, while you're there, we make a small injection of that medicine, like Bimix or Trimix, into the penis, into the sponge, and we try to get you to get an erection. We step out for 10 minutes, you think dirty thoughts, and then we come back in, we re-ultrasound the penis. And if we're seeing that the blood supply is working, that means that we can get that penis to work again. If the veins are not working, because you need those veins to collapse and those veins to stop draining the penis, it's working. It can work. We can get you there. And I'm more than happy to take that person down the path of injection therapies. But if that guy is not getting erections, if those veins are what we call having a leak, in other words, those veins are not collapsing from prostate cancer surgery, then it's time for an implant because it's going to be a guarantee to restore sex life. And that's pretty much the motions that we go through. There's a question here about procedure to reduce an enlarged prostate. I don't want to be rude. That's a totally different subject, and that's about a 10-hour lecture. There are so many procedures to reduce the size of the prostate. I will be doing talks on that in the future. You're more than welcome to keep an eye on those through the emails. And but I apologize. I'm not gonna answer that right now. How long would you take off work after surgery? I would say at least a week, if not 2. Now, the good news is that everybody's working from home right now. And so right now you can have your surgery. You can convalesce at home. Remember, lather, rinse, repeat. And you can do that from your desk at home and on your computer. Wake up, start icing the penis and your genitalia from the swelling, take your antibiotic, take your pain medicine, and as long as you're not, all looped out from your pain medicine, answer your emails, do a Zoom and stuff like that. But as far as like getting back to physical stuff, getting in your car, that's usually a week. I want people walking. You can go up and down stairs. You can take a shower after the drain is removed. You can take a bath a couple of days after that. But when it comes to labor and walk and maybe lifting some stuff, I'm going to want you to take a good 2 to 3 weeks off. Now, there are some people that we can activate this device pretty quickly. So we didn't talk about that in the beginning parts of the lecture, but we need to heal from this. It's a surgery. It's just like having your knee done, your hip done. You need to heal. There are some urologists out there that start the implant working. In other words, they teach their patients to pump it up at about 3 weeks. I usually do about 4, 5, 6 weeks, just because I want optimal healing. I don't want any damage. I don't want to have to go back and things like that. So I hope that answered your question. And it's usually on average a good 2 weeks, maybe 3, but a lot of times people can work from home these days. Does it affect ejaculation? It should not affect ejaculation because there's still stimulation to the penis. It does not affect sensation. And as long as there's sensation, as long as there's the emotional component of climaxing, the ejaculation should be consistent and the climax should be consistent. Now, if you've had prostate surgery like prostate cancer removal or what's called a TURP, which is a scraping of the prostate, or if you're taking prostate medications like Flomax or finasteride, then you may have ejaculation problems to begin with. That's a whole separate subject. But it should not affect the ability to climax. It should not affect the ability to ejaculate. Let's see, medications supplement to assist in orgasms. Tough question. There's a medicine out there called cabergoline. Cabergoline is there to stimulate your pituitary gland. Your pituitary gland lives right behind your eyeballs, and it's very involved with triggering testosterone production by making hormones called LH and FSH. So this medicine is there to try to trick your pituitary gland to get surges in testosterone to try to help with an orgasm. I'll be honest with you, I don't do a lot of that work. I sometimes will involve an endocrinologist with that just because it's a medication more commonly used by an endocrinologist. but that's the only one that I'm aware of to help with orgasms. Next question. Does an implant have an adverse impact on playing sports such as golf, basketball, tennis, running, or yoga? No, it does not. It will make your golf game better. It will make your basketball shooting more accurate. Why? Because you're going to have sex again. You're going to feel more confident. And you're going to tell your buddies, guess who got laid last night? Just to be honest. It shouldn't, I mean, in the beginning, you're not going to be as physical because you're sore. You got to heal up. You got an incision that's got to get better. But down the road, it should not affect you in the slightest. Next question. How does the procedure reduce the enlarged prostate affects the erection and the ejaculation? Okay, so the procedure does not affect anything with an enlarged prostate. All right. And so it has nothing to do with your prostate. We're just operating near your prostate. I want to reread this question. How does the procedure to reduce the enlarged prostate affects the, oh, I see. I take that back. Let me rephrase that. So procedures to affect your prostate, like I mentioned before, that their goals are to get you off of your erection to get you off of your prostate medication. So if I have a patient that is having erectile dysfunction from, say, Flomax or finasteride, and we need to get them to have sex again, then I will either switch their medications around and use daily tadalafil instead of Flomax, because I can do that with some people. Or we can do prostate surgery to reduce the size of the prostate so they can get off their prostate medications altogether if I think that those medications are causing the erectile dysfunction and the ejaculation problem. The dilemma is that there are some prostate surgeries that will cause men to never ejaculate ever again. There are some procedures that will spare the ejaculation. I hope that answered your question. All right, I did my best with that one. Next question. Does Trimix injection area is 2 o'clock or 3 o'clock? The injection area is either between 2 and 3 o'clock or between 9 and 10 o'clock. In other words, if this is the penis, I'm looking down the shaft, and this is the top of the penis, this is the bottom of the penis, the injections are like either here or here, and you want to switch sides. Why? You just beat up this side on Saturday. Let's say you're lucky enough to have sex on Sunday, put the injection on this side. And so those are the ranges. You never want to do it underneath. You never want to do it on top. Why? On top is where the nerves are. So you're just going to poke yourself in the nerves and that's going to hurt. And underneath is your urethra. That's where the pee comes from. And if you want to see stars and little Tweety birds going around your head, inject yourself in the urethra. You're not going to be too happy. Next question. I am not sure if I have ED. Sometimes I have a firm erection. Sometimes it takes time to get to that level. Is that normal? Yep, you are very normal. And so erectile dysfunction is not a constant thing. Some guys have good days and bad days. Some guys have good weeks and bad weeks. I've seen guys have good years and bad years. When it's consistently bad, that's when it's time to take action. When it's having a bad moment, that's where we use medications like Cialis and Viagra, or even some guys, I'll give them the injection so they can really have a good sexual experience and not have to worry about performance anxiety. I try not to do that so much. But if you're getting good erections, like if you wake up with an erection, you do not need an implant, okay? It will be, in my opinion, it will be malpractice to put an implant in you. And so I would not go down that path. If there's more, hold on. I get erections, but they go down too quickly. So I think there's two ways of answering that. And so there's two scenarios with that. One is some guys climax too quickly. All right. In other words, they're getting intimate, foreplay, they have intercourse, and then they ejaculate within a minute and they're done. It's time to roll over and go to sleep. So if that happens, we can use medications like tramadol. Tramadol is a pain medicine, but in Europe, it's used for erectile dysfunction, for helping guys maintain a longer erection, because it's a medicine that plays with the serotonin and norepinephrines in your brain to allow those nervous system, that part of your nervous system, to calm down. If that part of the nervous system calms down, you can maintain your erection longer to have a better sexual experience and ejaculate maybe 3 or 4 or 5 minutes later, or 15 minutes later, depending on what you want. The other thing that happens is you get your erection, you start to have intercourse, but then you lose it and you can't get it back. Okay, that's where Viagra comes in, the injections come in, and even an implant in this situation. So if I have a guy that's getting just these partial erections, the erections are good enough for penetration, but not good enough for sensation, not good enough for the partner, then we would certainly start considering implants for that patient. Next question. I get erections, but a no ejaculation. So that sounds hormonal. So for someone, that's something where I would look into what's the hormone status. In other words, is there a testosterone issue? The second thing I would go over, what's their medications? Are they on Cialis, excuse me, are they on tamsulosin? Are they on Silodicin? Are they on finasteride, dutasteride, things like that? And the other question is, what's going on with the climax? Because if you're climaxing, that tells me something. If you're not climaxing, that tells me another thing. So those are some of the things we would get into. Next question. Cialis gives me a terrible headache. Should I try a different one? Yes, plain and simple. If Cialis is giving you a headache, Viagra. If Viagra gives you a headache, Levitra. If Levitra gives you a headache, Stendra. If they all give you a headache, bummer. You may have to take a Tylenol or Motrin at the time of taking those medications. If those medications are not working well and still giving you a headache, then it's time to move on and start thinking about injection therapy. Let me know if there's any more questions. We're moving on to about 45 minutes here. So prosthetic surgery is a urologic subspecialty. I'm one of those urologists that does a handful of, well, more than a handful. I do a bunch of these per year. We want to go to someone who has a nice experience with it. On behalf of Coloplast, in the background is Shelly, who's been helping out, very involved with these lectures, and Ketia, who is our implant rep. I can't thank them immensely for helping us out. And of course, for doctors Rut Patel, Neil Patel, Vishal Bolani, Casey McCullough for helping me out with this lecture. And I think that's kind of all I got, guys. I'll stay online here for a couple more seconds, maybe a minute. If you have more questions, please type them in. I think we did a good job of covering everything.